For today, what I'll talk about is pathophysiology, the diagnostic algorithm, and treatment. I'll try and combine it together as we go along with the cases, with a focus on nutrition and diet as the primary part of the treatment modality. So I'll try and finish in the 20-25 minutes, so we have some time for questions at the end. So we'll start with the kidney and how amazing and flexible and adaptable it is. And so the minimum concentration or urine osmolarity that the kidney can get to is anywhere between 50 to 100 milliosms per liter. And the maximum is 1200 milliosms per liter. The normal intake in a normal diet is about 600 to 700 osms. And so at the minimum concentration of 50, the body can put out up to 12 liters. And at the maximum concentration of 1200, the urine volume can be 500 ml. So based on how much water we drink, the brain and then the kidney in response to that will adapt the osmolarity to excrete the volume that we have taken in terms of water and the osmolarity that we have taken in terms of solute. And hyponatremia is a water retention issue, and ADH is the main defense against hyponatremia. So let's talk a little bit about how osmolarity is sensed and regulated. So on the left side is osmoregulation, which is measured by sodium concentration. We sense the plasma osmolarity by the sensors which are in the hypothalamus. And then these hypothalamus receptors will either secrete ADH or generate thirst. In response to ADH, we have water reabsorption. And in response to thirst, we have water intake. And so that will increase water in the body. And if the osmolarity is low, then both of those get shut off, ADH and thirst, and we have water excretion. If there is any problem in this system, then you can have hyponatremia or hypernatremia. So unfortunately, the name has sodium in it, but the body senses and regulates it through water. And so hyponatremia and hypernatremia are water problems. In contrast, volume regulation, which is measured as total sodium or is effective total sodium in the body, is sensed as effective circulating volume by the carotid sinus, afferent arteriole, and atria. Based on whether the volume is high or low, you will have activation of the renin-angio-aldo system or switching it off, natriuretic peptide, sympathetics, and as a last ditch, ADH. The predominant mechanism by which these work is urinary sodium excretion or urinary sodium retention. And if there are problems in this system, you will have volume depletion if the volume is low, or edema and volume overload if the volume is high. Again, because the body is regulating it through sodium, volume is actually a sodium issue, and osmolarity, because the body is regulating it through water, is actually a hyponatremia are water issues. So now just looking at ADH, so the white circles are ADH and changes in osmolarity. So it's a very tight linear relationship between osmolarity and ADH. Osmolarity goes up, ADH goes up. Osmolarity goes down, ADH goes down. In comparison, the black circles are volume changes. As your volume goes down, for the first 5-10% of your volume decrease, you are reliant on renin, angio, aldo, sympathetics, and the natriuretic peptide being turned off, while the renin, angio, aldo, and the sympathetics go up. And so for the first 7%, ADH does not do anything. Once your body loses more than 7% of volume, as a last ditch effort, ADH is now being secreted in response to volume. And this can then overwhelm what the regulation is happening through osmolarity. And this is a last ditch effort to save the organism. So now let's come to cases and kind of how we diagnose and what algorithm we can use. So we have a 24-year-old male who is an alcoholic and presents to the emergency department after being found down by his family. His blood pressure is 120/80 and he appears euvolemic. His serum sodium is 128, serum osmolarity is 265, urine osmolarity is 60 and urine sodium is 15. What's his cause of hyponatremia? Is it 1, pseudohyponatremia, 2, beer potomania, 3, volume depletion, or SIADH? So I'll kind of share you my algorithm for hyponatremia. There's lots of different algorithms out there. All of them use the same basic structure, and so you can use any of them. The first thing that I look at is the serum osmolarity in the setting of hyponatremia to see if it is serum osmolarity is actually low. So that means that this is true hypoosmolar hyponatremia. If the serum osmolarity is normal or high, then I would look at pseudo-hyponatremia and hyperglycemia to assess which of those is the etiology for the hyponatremia that has been diagnosed. And then if this patient, it is 265, so this is true hypoosmolar hyponatremia. The next step I look at is urine osmolarity. In the setting of hyponatremia, which is hypoosmolar, the brain should shut down ADH. In response to brain shutting down ADH, the urine osmolarity should be between 50 to 100. So it should be less than 100. If it is less than 100, then the brain and the kidney are doing what they're supposed to. And what is actually happening is that this person is overwhelming the body's ability or adaptability of the kidney. And so that is primary polydipsia or beer potomania. So that is what this patient has. And so this is beer potomania. The take home message is that the low urine sodium that we saw was due to the low osmolarity of the urine. Now let's look at what the body does and how does it adapt. So let's take a normal person who has a normal 600 milliosm intake and 1 liter water intake. So the kidney and the brain will adapt the ADH level, and the kidney will excrete 600 milliosm per liter with 1 liter urine, and the body will be in balance. Next, let's say the same person next day drinks 2 liters of water. So now he has 2 liter water intake. The body will adapt the osmolarity of the urine through ADH. Now it will secrete 300 milliosms per liter and then have 2 liter output and again be in balance. Let's say that he drinks 6 liters of water, or in that case, the ADH will be almost completely shut off and the urine osmolarity will be 100 and they will excrete 6 liters of water, again be in balance. However, if someone has beer potomania, what happens is that their solute intake is low. And dominantly solute is from salt and protein. And in case of beer potomania, it only has calories and doesn't have any salt or protein in it. So let's say that their water intake was 4 liters. Even with a urine osmolarity of 100, with only 200 milliosms, the body can only excrete 2 liters of fluid or urine. And so the extra 2 liters is going to be retained in the body. And if this person continues to do it every day, his sodium is going to continue to come down because of this retained water on a daily basis. In case of primary polydipsia, the solute intake is same, but the water intake will have to be massively high, somewhere in the 14 liter range. The urine osmolarity would be in the 50 to 100 range. If it is 50, the person would be able to excrete 12 liters. If it is 100, they'll be able to excrete 6 liters. So based on how low the kidney can go, you will have a positive balance of 2 to 8 liters. And this is what primary polydipsia patient will have to do every day for him to remain hyponatremic. Otherwise, the kidney will be able to excrete the additional water and the sodium will come up. So again, so beer potomania and tea and toast or primary polydipsia is too much water intake for the amount of solutes that the person is taking. So now let's go to case 2. So this is a 55-year-old male with cirrhosis from alcohol and presents for a scheduled endoscopy as part of his liver transplant workup and is noted to have an asymptomatic serum sodium of 128, the serum osmolarity of 260, urine osmolarity of 450, and urine sodium of 80, and he's not on any diuretic. What's the cause of his hyponatremia? Is that cirrhosis, which causes effective circulating volume depletion, beer potomania, SIADH, or true volume depletion? So again, we'll go back to the algorithm, and serum osmolarity is low, urine osmolarity is high at 450. So that means that ADH is present in the system and the kidney is responding to that ADH. Now we look at urine sodium, and if the urine sodium is low, less than 20, so what that tells you that the renin-angio-aldo system is active and the ADH is in response to this volume issue. So then that would mean that it is either volume depletion or effective volume depletion in terms of heart failure, nephrotic syndrome, or cirrhosis. So the exam would be easily able to identify, is this someone with true volume depletion due to either GI loss or some other loss? Is this someone with effective volume depletion in terms of cirrhosis or heart failure? This patient, the urine sodium is 80. So this patient has SIADH. Before you label someone with SIADH, you should also assess them for hypothyroidism and hypocortisolism. And so that would be something that you would do. In this case, the patient had actually started a recent SSRI or serotonin reuptake inhibitors, and that was the cause of his SIADH. We stopped the drug, SIADH went away. So another patient, 70-year-old male with lung cancer, presents in the clinic with asymptomatic sodium of 125 with a serum osm of 260, urine osmolarity is 900, and urine sodium is 150. So all of these criteria meet SIADH. The questions now in terms of management, how would you manage him? With just fluid restriction of 1 liter per day, fluid restriction plus salt adds 1 gram 3 times a day, fluid restriction of 1 liter and furosemide 10 milligrams twice a day, or normal saline 100 ml per hour for 2 liters. So let's look at how the answer is going to be fluid restriction with furosemide, but let's look at how we approach this. And we'll come back to the balance in terms of water intake and solute intake that we had looked at. So in SIADH, the predominant driver is not the body's ability to change the ADH level and the kidney's adaptation to it, because that is being driven by the ADH coming from whether it's the cancer or nausea, vomiting, or lung disease, whatever is the driver of the ADH, that's going to control the ADH level. So the main driver of how much urine is going to come out is going to be dependent on the solute that we take. So let's say the solute intake of 600 milliosm, and let's say that the urine osmolarity for this person based on his ADH level is at 200. So then they will excrete 3 liters. If they started with hyponatremia, they'll get better because water intake is only 2 liters. And so they have a negative balance of 1 liter. The extra water is coming out. Hyponatremia, if they would get better. In contrast, if you have someone whose ADH is at a higher level with a urine osmolarity of 400, and they also eat 600 osms and drink 2 liters, they'll excrete this 600 osms in 1.5 liter. And so there'll be a positive balance of 0.5. And so their hyponatremia is getting worse on a daily basis. But if you put this person on a 1 liter fluid restriction, they keep eating their 600 osms. Now this 400 osmolarity is going to get the 600 milliosms that they eat at 400 osms per liter will get excreted in 1.5 liters. And so they'll be in a negative balance of 0.5 liters. And so the hyponatremia is getting better every day by 0.5 liter a day. In comparison, if you have a higher ADH level, once you get to 600, now, even if you, and you take 2 liters, you're at positive 1 liter. If you fluid restrict them to 1 liter, what ends up happening is the 600 milliosm per liter will get excreted in 1 liter. And so your net balance is equal. So even if you fluid restrict someone, but their urine osmolarity is at 600 milliosm per liter, they will be in a net water balance and their hyponatremia won't correct, but it will be stable. So now you have 2 options. One option is to add Lasix or furosemide. And what that will do is bring the urine osmolarity down from 600 to close to isoosmolar, around 250 to 350. So we've taken 300 as an example. Now this person will excrete the 600 milliosm in 2 liters. If they're fluid restricted to 1 liter as well, they'll be negative 1 liter. And that will allow the hyponatremia to get better every day with this extra free water excretion. If in addition to that, you increase their salt, urea, or protein intake and get them to a 900 milliosm per day diet, then on a 300 milliosm fixed osmolarity, they'll excrete 3 liters. And so they will correct quicker than the person above, and they will be negative by 2 liters a day. In comparison, if you have a patient like the case that we're describing here, who has a 600 milliosm intake, 2 liter water intake, but urine osmolarity is 900, they're going to excrete the 600 milliosms in 0.7 liters, and they'll be positive 1.3. So to make them negative, in terms of water balance, you would need to increase their osmolar intake, restrict them to 1 liter, and give them furosemide, drop their osmolarity from 900 to at least 450. If you can get them to 300, even better. And then they will put out 2 liters and be negative. So take-home message is, if the urine osmolarity is more than 600, diet in terms of fluid restriction won't be enough. And even with salt tabs or increasing protein intake, it will be hard to get them to correct their hyponatremia. In these situations, you will need furosemide to lower the urine osmolarity to help correct the hyponatremia. Now we'll take another patient, 30-year-old female with lab cholecystectomy. And post-op, she's been receiving D5 with half normal saline at 100 an hour. Post-extubation, she has significant pain and nausea and is not eating much. She just continues on the maintenance IV fluid. Next day morning, she's found to be altered and incoherent. Labs reveal a serum sodium of 115 with a weight of 60 kgs. What treatment would you prescribe? Free water restriction, change the IV fluids to NS at 100 an hour, 3% hypertonic saline at 100 ml bolus, free water restriction, and 3 gram salt tabs. So the answer is 3% hypertonic saline at 100 ml bolus. Another option would be to do it on a drip. So we'll go over the drip, and then we'll talk a little bit about the bolus as well. In terms of treatment, the 2 basic principles for hyponatremia are: you want to raise the sodium at a safe rate, and you want to treat the underlying condition. But the biggest question is the patient symptomatic or not? If they are symptomatic, then you need aggressive correction at 1.5 to 2 MEQs per liter per hour for the first 3 to 4 hours, and then less than 12 in the first 24 hours. The rate of correction is 48 hours. So it's not that 10 to 12 every 24 hours to continue. It's only 10 to 12 in the first 24 hours. And then after that, you do it at a slower rate. So let's calculate the sodium deficit. So if you want to calculate the sodium deficit, it's 0.5 into the lean body weight multiplied by 140 minus the current sodium. So for this patient, 0.5 into lean body weight, correction sodium would be 0.5 into lean body weight was multiplied by the target minus the current sodium. For this 60 kilogram female with a sodium of 115, our goal is to raise the sodium by 4 to 6 in 4 hours, and 10 in 24 hours. So 4-hour correction would be 4 millicoulomb for the 4 hours, 4 into 60, which is her weight, into 0.5. So that's 120 MEQs. 3% has 512 MEQs per liter. That's 2 ml per MEQ. And so 120 MEQs would be in 240 ml. And so if you want to correct 240 ml over 4 hours, that's 60 ml per hour. You could start this person on a bolus of 100 ml, repeat the sodium in 3 to 4 hours, and then give additional boluses. Or you could put them on 3% at 60 ml per hour, and then monitor the sodium and adjust the rate based on their actual correction. For the next 20 hours, you would want to do a slower correction. So if they were following what your math is saying, then for the next 20 hours, you would want to correct by an additional 6, get them to around 10. And so that would be 0.5 into 60 into 6. That would be 180 MEQs. And that would be in 360 ml of 3%. And to give this over 20 hours, you would drop the rate to 18 ml per hour. So you would start at 60 ml per hour for 4 hours. If the math is working correctly and they're correcting as you've calculated, then you would decrease the rate to 18 ml per hour for the remaining 20 hours and then reassess over every 4 hours. So another shortcut would be to do 0.5 into weight into ml per hour. So that would be about 30 ml per hour, and you could start that. Another version, as I discussed, is 100 ml 3% bolus and repeat every 3 to 6 hours based on the sodium correction. The caveats for the sodium deficit calculation and its correction are that it only applies to administration of salt without water. So salt tablets, hypertonic saline, and not normal saline. It's only an estimate, and so serial measurements are needed. And it doesn't take into account ongoing losses or isoosmotic losses that the person may also have, which may need additional correction or separate correction. So now we'll take a look at a couple more sicker patients. A 30-year-old female with severe diarrhea with 5 to 6 days of diarrhea and presents to the emergency with hypotension. Again, serum sodium is 115 with no neurological symptoms. So she receives 5 liters of normal saline over 6 hours, and she's already corrected to 125 and now is putting out copious amount of dilute urine every hour. What would be your next step? Stop the IV fluid, monitor clinically for osmotic demyelination, give D5 and DDAVP, or monitor labs and only intervene after she reaches a serum sodium of 130. So the answer is that you would want to start D5 and DDAVP and do something called re-lowering for someone who has had rapid correction. So let's talk about osmotic demyelination. So that's rapid correction leading to central demyelinating lesions. And this is due to osmotic shrinkage. The symptoms are typically 2 to 6 days after correction and can include paraparesis, quadriparesis, dysarthria, dysphagia. And high clinical suspicion is required for confirmation by CT or MRI, though the lesions may not be detectable even up to 4 weeks after. The risk factors are more than 12 correction in 24 hours and correction to more than 140 in the first 2 days. Hypercatabolic people, malnourished, and alcoholics are at a higher risk. The treatment is none after you've gotten it. If you get them before symptoms or even early on in symptoms, you can reverse it by giving free water and DDAVP, re-lower the sodium, and then bring it up slowly over time. And this is based on case reports and animal studies. Some of them are dominantly done by Dr. Supart from France. And they've shown in elegant animal studies that this is something that you can do and the neurological damage is prevented or reversed. So the last case that we'll talk about is a 70-year-old female with lung cancer who presents with change in mentation and has a weight of 60 kgs. Serum sodium is 115, potassium is 2.5, urine osmolality 600, urine sodium 75. You follow the algorithm. The serum osmolality is low, urine osmolality is high, urine sodium is high. So this is a SIDH, likely due to the lung cancer. You do your calculations of sodium deficit and you want to give 300 MEQs of sodium over 24 hours. You plan your 3%, but you also have to give potassium. So if you're giving potassium, how should you adjust your sodium? So option number A is you don't adjust the sodium, you give both. Option number 2 is 220 of sodium. So you reduce it by the amount of potassium you give. 380 MEQs, option 3 is you add the potassium as well and give additional sodium. And then D is you only give sodium and you don't mess with potassium at all. So let's look at what would happen. So when you give potassium, it will first go into the extracellular fluid and then it will go into the intracellular compartment and the intracellular potassium concentration will go up. Then water will move from the extracellular fluid into the intracellular fluid and compensation wise, sodium will go up as well. So giving potassium to someone who is hyponatremic is the same as giving sodium. And so the answer is B. So you would reduce the 300 to 220 of sodium and 80 of potassium because giving potassium is same as sodium. So I'll stop here. And if someone wants to hear more from my side on hyponatremia, my talk is already on Dr. Vic Vegcha's YouTube channel. So they can look at that here. And I'm happy to take any questions if there are any at present.
Thank you, Ajay. That was an excellent expose, illustrated so beautifully by cases. Rasika, you would like to take it on?
Yeah, it was really good. You've taken it case by case and elaborated, and I've also heard your talks on the YouTube. Excellent. Um, I was just wondering, how would you manage a chronic SIDH? So,
So, ma'am, the chronic SIDH one would be if there is something that we can fix and correct, you would want to correct that. But my assumption is that that's not possible. That's why they have chronic SIDH. In those situations, I would focus on the diet and intake. If they have nothing contradicting taking a high salt diet, I would do high salt, high protein, and fluid restriction. And usually, with that combination, unless their SIADH is a really high ADH state, in which their ADH is in the 600 to 900 range, if they're in the 200 to 300 range, high salt, high protein, fluid restriction would be able to manage them and get them to a normal sodium. The only problem is they have to do it on a daily basis and continue and make this a part of lifestyle. If their osmolarity is 600 or higher, even this salt, protein intake, and fluid restriction won't be enough. So usually in those situations, we will need to put them on furosemide. They don't need much. They usually need 10 milligrams twice a day, kind of knock out the loop, knock out their concentrating capacity. And then the other things that we talked about, the salt, protein, and the fluid restriction, in combination with the furosemide, would manage these patients in the long run.
do you ever have to use tolvaptan in low doses?
Ma'am, usually I try and avoid using tolvaptan. And that's because most of the time I'm able to manage my SIADH with this combination. And the other reason that I try and avoid tolvaptan is one, they will only maintain the sodium as long as they're taking it. So now I'm giving this medicine to someone for the rest of their lives. So that's one. Two, when we start tolvaptan, even especially in SIADH patients, they are at the highest risk in the first 24, 48 hours of overly rapid correction. And even Takeda, that is made tolvaptan, they did a trial of their own, and they started with 7.5 milligrams and even 3.75, meaning a quarter of the 15 milligram pill. And 1 in 10 patients that they gave to their SIADH patients had overly rapid correction in that. And so in my mind, usually I manage with medicine, with the diet, fluid, and Lasix, and try and avoid tolvaptan if I can. I know occasionally we may need to use it. In those cases in SIADH, I would start with like a crushed low dose and slowly see the response, because the main problem is going to be in the first 24, 48 hours.
Eileen?
Yes, quickly, we are out of time already. I just want to tell Dr. Ajay that when the patients come to us in our nutrition clinic, what is the one advice we should be giving to the patients who come with hyponatremia?
So, ma'am, again, I would focus on three things: high salt, high protein, and fluid restriction. Those three things together would be what I would focus on. The problem in India predominantly is if you have a hypertensive or cirrhotic or heart failure, then you can't give them the salt. And protein in an Indian vegetarian diet is very hard to push up. So you really need to ask them to take supplements. You can't ask them to just do dal, dahi, paneer, soya bean. You can't get their protein up. So usually for Indian vegetarians, I am pushing them for additional protein biscuits, protein powders, and asking them to take it as dawai or medicine, because otherwise you can't get their solute. Getting to 600 to most of the people who have hyponatremia have some component of low solute intake. So you really need to push their solute intake high. And with low blood pressure or heart failure or cirrhotics, salts out. So then you get stuck, and then you really need to push their protein. And so that's something which I routinely do. I push and push and push on protein.
Thank you, Dr. Ajay. It was indeed a very good lecture.
Thank you so much, ma'am.
Thank you, Ajay. Excellent.